Okay, everybody, take a seat. Let's get started, and we'll actually probably get out of here about an hour early today, if that, and which will be good. I'm sure there'll be no objections from you. So, first thing is I have no disclosures, no financial conflicts. I want to talk about the epidemiology of addiction itself. We've discussed that a little bit today. I want to talk about the brain disease model of addiction. And then I want to talk about physician health program style of management for patients with addictive disorder. And so we will get started with just some basic facts about addiction. You hear everything from 8 to 12% lifetime prevalence of addiction. So we're talking about 30 million Americans, very common, 31 million. Unfortunately, around 10% get treatment. So there's a huge disparity with other chronic conditions like hypertension or diabetes. And one of the things I really like to hit on is the stigma of addiction. Part of the reason for this is addiction is so heavily stigmatized. If someone has a blood sugar of 312, we don't say, oh, they have a dirty blood, you know. But if someone has another drug in their urine drug test, we say, oh, they've got a dirty test. Folks with addiction, their brain disease is that they've got to use drugs. That's part of that survival part of the brain that's diseased. So they're behaving exactly the way a person with an addictive disorder behaves. I think we've got a lot of work to do. Unfortunately, when someone has an addiction, the behavior is going to be a lot different than somebody with uncontrolled diabetes. Both of the conditions, though, involve patient choices and lifestyle. Unfortunately, someone with a genetic predisposition for addiction, the manifestation will be different. But there's a lot of similarities there. 40 to 60% of people relapse after treatment. With opioid dependence, I think it's a lot higher. The dysphoria with opioid withdrawal is really intense and worse than other drugs. So, you know, if you include cigarette smoking and cigarette-related deaths, addiction is really affecting a lot of folks negatively. If you practice primary care, about 1 in 4 visits will involve a patient with an addictive disorder. About 1 in 5 visits will involve writing a prescription for a controlled substance. So, and if you're talking about any psychiatrists here? Oh, awesome. Psychiatric nurse practitioners? Any nurse practitioners? How many folks here have a DEA? I guess everybody. Okay. Yeah, with a psychiatric practice, you know, by most estimates, about 50% of the patient population has an addictive disorder. He's going like this. I would tend to believe that too. But knowing this, look back on in your training. How much time was spent educating you about treating addictive disorders? Well, you know, we all get pretty good at learning how to, you know, watch somebody who's going through detox, and, you know, we are great at treating complications of addiction. But as far as treating addiction itself, the amount of training we get is very limited. I think my background is family medicine, and then I did a fellowship in addiction medicine. But, you know, during medical school, residency, and family medicine, I don't think I got 2 or 3 hours total. And even that was not what I would consider to be solid. So we have a lot of challenges. So if we're looking at other chronic conditions like skin cancer, we all buy into prevention at an early age. This, you know, putting suntan lotion on a child is considered a good thing to do. We would not wait to treat skin cancer or melanoma until it gets to this point. Same thing with other diseases, diabetes. Early treatment is better. Some of these are better to look at before lunch than after lunch. But at any rate, when it comes to addiction, in most cases, or not in most cases, but in a lot of cases, the patients progress in their addiction much further than other chronic conditions. And even then, when they come in for treatment, a common approach is that treatment is punitive. Like I've seen folks with medical students with 3 or 4, one medical student had 3 DUIs, and I was talking to a person about that, and they were saying, well, he's doing good, he hasn't had to have treatment yet. And then they immediately realized what they said. It's like, wow. We wouldn't approach any other chronic condition like that. So addiction, we started learning about the brain kind of relationship and addiction really in the 50s with the rat experiments. We figured out if you stuck an electrode into the nucleus accumbens and stimulated it, that rats loved it. And you had to get it right in the right location. Then we figured out if you injected heroin there and it bound to receptors in the nucleus accumbens, you get the same effect. Then in the 80s, we found out the same thing with cocaine, which was not supposed to be addictive. And as an aside too, you know the way we, Dr. Williams' presentation and showing the early pharmaceutical advertising, like for amphetamines and various things, you'd think today we're beyond that. As far as with all our scientific ability and everything, but really in many cases we're kind of in the same jam. And there's a lot of money that is spent influencing us and the way that we practice medicine. And I have nothing against pharmaceutical companies, and I have nothing against controlled substances. I think that they are great. They alleviate suffering when used appropriately. And same thing with, you know, pharmaceutical companies. But if you look at the top 10 largest pharmaceutical companies in the world and look at their profit between 2003 and 2012, in that 10-year period, $733 billion profit. That's not operating expenses. That is profit. Almost $1 trillion. It's incredible. So there's a lot of money that goes into it. In one of my other talks, I talk about some of, you know, the fines that are being paid by pharmaceutical companies for misbranding. Almost all of them. Of those 10 largest, 8 have paid billion-dollar fines for misbranding drugs. So it's almost like we've got a system that's, in some respects, fraudulent. Like a company will advertise for something, it's proven false, they pay fines, whatever, and then they keep on going. So we really don't know what to believe in many cases. That's another reason that practicing medicine now is becoming more frustrating and challenging. So anyway, if you look at a rat brain, a human brain, very, very similar, except for the size of the cortex. So we assume since humans have got this big cortex, we should be able to control behavior. And I've heard patients and families many times say, well, I don't know why he drinks so much. I drink 1 beer and I stop. That's all I want. You know, he drinks 1 and he just gets started and he'll drink a whole case. What we know is that the addiction, the disease really is primarily taking place in the midbrain. And the midbrain will always trump cortex. So, you know, the survival impulses are really located and generated in midbrain and brainstem. And those will always trump cortex. And if you don't believe it, think of what we would do here in Hattiesburg if there's a huge water shortage. We had to pay $50 for a gallon of water. Imagine that. Imagine what folks would do, law-abiding Christian people, if they hadn't had water for 2 days. When survival is at stake, think of the behavior that would happen. And this is kind of where folks with addiction live. Their relationship with the drug is like that. So we refer to the lizard brain. Certain behaviors are automatic. Survival has always been tied to pleasure. and from either a creation standpoint or evolution or both, or however you want to look at it, survival is good. It's associated with pleasure. And to some degree, dopamine is the neurotransmitter that's involved. And it's a lot more complicated than that. But just looking at it simplistically, when we're talking about addiction, we're talking about big hits of dopamine. And ultimately, for folks with an addiction predisposition, their brain gets fooled into believing that that dopamine hit is a survival event. So getting that dopamine hit from the drug becomes survival. Just like if you're starving and you see food, or if you're dying of thirst and you see water, you know, the prospect of dopamine is going to some degree, activate the reward pathway. So these are the opioid binding sites, the green areas. Opioids bind to these, produce an effect, whether it's constipation, analgesia, what have you. When they bind to the receptors in the orange area, which is kind of the reward pathway, what happens? You get a release of dopamine, and reward pathways are activated. You start to experience pleasure, and many different parts of the brain are involved, but it's a good thing. Like Dr. Mutager was talking about, folks, and someone asked a question about how can you become addicted with the first dose even, much less the first prescription. Some folks with addiction respond to that dopamine hit differently than other folks. If you look at, you can radioactively tag dopamine molecules and dopamine receptors and then do PET scans. And folks with addiction, either because of the drug, before, we don't really know, but at the end of the day, they have decreased concentrations of these dopamine receptors. So when they experience this dopamine hit, you know, the results are variable. And for folks with addiction, it's a really, really powerful event. If somebody experiences excitement and generation with their first dose of opiates, if someone says, man, I took it and I was out, you know, cutting my grass at 3 in the morning, my neighbors got mad at me, and I've heard this like 5 different times. That's a paradoxical reaction. And if that happens, your antenna should be going up. This is probably not a good person to put on chronic opiate therapy. So, okay, this is a really great article by Nora Volkhaus, who's director of NIDA, and it really describes a brain disease model of addiction. It's in the New England Journal, published in this year. So, Dr. Volkhaus describes the stages of addiction as would start with binging and intoxication. That's followed by withdrawal, physical withdrawal from the substance, and a negative affect. And then that's followed by preoccupation with using again, and then anticipation of it. That's followed by binging, intoxication, and it just keeps going. So neuroplasticity refers to the potential that the brain has to reorganize by creating new neural pathways. Neuroplasticity is involved with addiction. The brain changes with substance use. It's also involved in recovery and recovery activities. So there's progressive behavior change during the process of becoming addicted. And ultimately, the brain circuitry becomes compromised, and many different neurotransmitters and various changes occur. So also many different parts of the brain are involved. It's not just the nucleus accumbens. You know, there's a relationship between the reward pathways and prefrontal cortex, an effect on executive function. And we're going to talk about our physician health program and what happens with physicians when they become addicted. And when you see anybody with addiction, there's going to be executive function dysfunction in every single case. Attitudes about the drug, relationship to it, denial, minimization, all these things represent really significant executive function problems. So these various parts of the brain are involved. hippocampus, memory, the amygdala, associated with the stress, emotions, dorsal striatum, nucleus accumbens. In 1939, the textbook of Alcoholics Anonymous was released, and Bill Wilson was a stockbroker, recovering alcoholic, who started Alcoholics Anonymous with a surgeon who was an alcoholic. Both of them had been trying for years to become sober, and they just couldn't do it. Then these two guys got together and put together Alcoholics Anonymous. But they wrote in 1939, alcoholic at certain times has no effective mental defense against the first drink. And they really got it right. And this is what we still see today. Trouble with impulse control, inability to access significant executive function to control behavior. This just shows the number of accidental overdose deaths in 2014. Over 47,000. The population in that 35-year period increased about 50%. The accidental drug overdose death rate increased exponentially, and it parallels the volume of opiates that are prescribed. So there's a direct relationship between the number of opioids prescribed and harm. This just shows Dr. Mutzeiger mentioned the number of prescriptions. In 2012, almost 220 million prescriptions just for oxycodone and hydrocodone. You can see a decrease in 2012 and 2013. I believe it'll be the same. I don't have 2014 data yet. But we're seeing a decrease in prescriptions. And what do you think we're seeing with accidental overdose death rate? The amount prescribed is decreasing, and yet we continue to see an increase. Why is that? Yeah. So in Mississippi, we're in the top 10 somewhere for prescribing opiates and benzodiazepines. Now, I do know in 2015 we wrote almost 500,000 prescriptions for Xanax, and like 2.4 million prescriptions for hydrocodone, and our population's about 3 million. So the last I heard, we were about number 6 nationally in amount of opioids prescribed per 100,000. That means our death rate should be about 6th, because we know that there is just about a parallel relationship between amount prescribed and death. But our death rates, I think, are underreported. And as time goes on, there's tighter and tighter requirements. So it's becoming a lot harder for a county coroner elected in his county to help out a family member who doesn't want a heroin overdose to be recorded as the cause of death. So instead of putting respiratory failure secondary to opiate overdose, it's just respiratory failure, something like that. So, but anyway, we're seeing more accurate reporting, and I suspect it's going to keep going up for a while. So, okay, adverse selection refers to the process that people who are most likely to be harmed by a therapy are the ones who are ending up on the therapy. And that's what we see with opioid use. The people who are most likely to be harmed, folks with comorbid psychiatric conditions, folks with addiction. You think of the billions of dollars profit that's made. You think of the billions of dollars that are used to market these drugs. When they do these studies, like for a pain drug, how does the FDA approve these drugs? First of all, when they do a study to determine whether drug X is effective at relieving pain, the first thing they do is eliminate anybody with addiction from the study, right? Anybody that has an adverse reaction, like it made me so constipated I couldn't go to the bathroom for a week, those people are eliminated from the study. So all you have left are the people who didn't have problems with it. And then they say at the end of 8 weeks or 12 weeks, what percentage of these folks say that they are getting good pain relief? And then they'll say, well, 60% of the people said they got good pain relief. Well, you cannot extrapolate long-term results based on an acute model. And that's Dr. Mutar was talking about the CDC guidelines. They point this out. So, but at any rate, this adverse selection is a real problem. And we've already talked about these CDC guidelines. But all these things kind of are working together to cause physician distress. If I mention electronic medical records, most people, I get a little blood pressure bump or a pulse bump. Or if you talk about prior authorization, that one is really, you almost have to have a full-time person in your office to deal with that. It's ridiculous. Many, many challenges. We're not financially incentivized to treat addiction, period. If you're a primary care provider or psychiatrist, you have got X number of hours and you have got to generate a certain number of patient visits if you want to stay open. So say you have a busy practice and you're seeing 30 patients a day or whatever, 40 patients a day. If you have one patient that comes in on high-dose opiate therapy and you want to talk to them about tapering or decreasing, how long will that visit take? Huh? 30 minutes at the least. Exactly. So if you're, 10 or 15 minutes per visit and you have that conversation, what's it going to do to your day in general? It's not a pleasant experience. The patients in many cases will leave upset with you. So the easy thing to do is just write the prescription and get them out. If you combine Joint Commission involvement, Fifth Vital Sign campaign. Now I found out just 2 days ago the AMA is going to finally push elimination of the fifth vital sign. Does everyone know what the fifth vital sign is? Pain. Entirely subjective finding. Not the same in two people. Totally subjective. Whereas the other vital signs a 10-year-old can do reliably in any person. So anyway, that's a good thing. But you got the Joint Commission saying, assess pain. If someone's in pain, treat them. Medical boards have disciplined doctors for not treating pain with opiates. This is like 5-6 years ago. So there's all these pressures. Basically, the system was designed or evolved into a system that enabled addiction. Really, that was it. If someone was going through heroin withdrawal and they couldn't buy heroin on the street or they didn't have money or whatever, what would they do to get a fix? Just go to the ER with some complaint of pain. And if the doctor didn't give them something for pain, they could complain. And then what would happen, if there are documented X number of complaints, the Joint Commission could get involved. How about physician pay scales being tied to patient satisfaction surveys? Another thing that's being looked at and that absolutely needs to be done is tying patient satisfaction scores to pain treatment is insanity, especially if opiates are involved. You cannot not enable addiction in that system. It's really difficult. So at any rate, all these things are going on. Practicing medicine is becoming more challenging. We talked about some of these issues. Oh, good night. MOC, maintenance of certification. What a racket. But anyway, but practicing medicine is still, it's the best. We all do it because we want to alleviate suffering. We want to make a difference and help our patients. So it's still really beautiful, and I'm really proud to be in the healthcare business. If you look at the culture of medicine, suck it up, get it done. Resilience is definitely expected. It's not taught. If a police officer is involved in a fatal shooting, do they let him go back on the beat that same day? How about that same month? No, they are pulled out and they go through pretty significant evaluation. However, a physician or a nurse practitioner or any provider can be involved in a horrific fatality. And then you go into the next room and someone might have an ingrown toenail. And So we are fairly stressed out. Asking for help is stigmatized. Mental health issues in medicine are very stigmatized. I really prefer to look at folks with addiction. I refer to them as people with an addiction problem or a patient with an addiction problem. I challenge my friend Dr. Mutziger to eliminate addict from the vocabulary. But really, truly, we are not in a place where we support each other yet. And there are actually potentially negative outcomes for self-reporting. You know, if you say, well, I've got a problem, you're diagnosed with depression or whatever, there can be some negative consequences. Characteristics of medical work. All of these things are ultimately a breeding ground for distress. So how do we handle distress? How do you handle distress? And these things are all intimately related to the prescription drug crisis. We're in the worst drug epidemic in the history of our country caused by prescriptions, period. So how are these things involved? Really the entire system of medicine probably needs an overhaul. And how we handle distress also does. In some respects, I think we may have reached like a critical mass in our ability to ignore stress and keep plowing through. And the reason I say that is because we're seeing more and more burnout. And so if we have healthy skills, good resolution. Unhealthy skills, potential harm to patients, literally. So that can be manifested in substance abuse, addiction, anxiety, depression, burnout, suicide, boundary violations, disruptive behavior, impairment. And then all of these things, how do they manifest? How do they manifest impairment? What's the relationship between patient harm and these things? Physician addiction is more common than the general population. Why is physician use of illicit drugs less than the general population? Yes, we can get prescriptions. We have access to the good stuff. Physician alcohol abuse higher. In one study, this 8,000 physicians, this was published in JAMA. This was the American College of Surgeons survey. And it showed that by self-report, 14% of the male physicians reported diagnostic criteria for alcohol abuse or dependence. They also reported a medical error in the last 3 months. So, and this is by self-report, so there is becoming a more solid linear relationship between alcohol abuse and major medical errors. What would you guess the self-reported incidence of female surgeon alcohol abuse is? For males is over 14%. What do you think? Higher or lower? 30, well, not quite 30 to 40, 24%. That's significant though, 1 in 4 female surgeons. So physician burnout, another study, this was a Mayo Clinic proceedings, and JAMA has been doing this a lot too. But so physician burnout 2011, 45%, increased to 54% in 2014. In that 3-year period, we've had a lot going on in that 3-year period. If you look at satisfaction with work-life balance, 48% in 2011, decreased to about 41% in 2014. So burnout is characterized and described by Maslow Burnout Inventory, which is a validated instrument to determine burnout in healthcare professionals. This triad consists of emotional exhaustion, depersonalization, and reduced sense of personal accomplishment. This depersonalization is where We look at the patients as the enemy. It's not like us, you know, it's we're this dehumanized perception of others. That's a dangerous place to be. And if I asked you to raise your hand, how many people have felt like that about their patients? We would be hesitant to admit it. But in the number of folks surveyed that report this is like 80% of physicians. So when all these things are together, you have burnout. So the first part of that triad, emotional exhaustion, these are the questions that are used to assess it, and higher ratings for these are associated with burnout. I feel fatigued when I get up in the morning. Working with people all day is really a strain. What's the difference between that and major depressive disorder or symptoms of depression? Very similar. Depersonalization. I treat some patients as if they were impersonal objects. I become more callous towards people. I really don't care what happens to some patients. Higher scores associated with burnout. The last part, this sense of personal accomplishment. I feel I deal effectively. I feel I'm positively influencing. I feel there's a good one. How many people can say this? I feel exhilarated after working closely with my patients. Anyone? One? That's it. That's impressive. So anyway, lower scores are associated with burnout. So if you look at physicians, 93% report moderate to high levels of depersonalization. Wow. So what are the effects of burnout? We talked about alcohol abuse, an association with burnout, suicidal ideation, burnout and depression, hand in hand, and we know that alcohol use has potential for major medical errors. So these effects are not minimized. As physicians, we almost say, well, burnout, suicide, these are all occupational hazards. We kind of minimize it and just suck it up, keep going. But it's becoming harder to deal with. So we talked about physician addiction already. That kind of leads us to our program. We changed our name to Mississippi Physicians Health Program. That's our name, and we're a subsidiary of the State Medical Association. We're a not-for-profit 501c3 company. We have a written agreement with the Board of Medical Licensure that allows us to function and allows us to do what we do. So our vision ultimately is a healthy Mississippi served by a healthy physician workforce. So our purpose is to provide a confidential, non-disciplinary mechanism to deal with physicians who have issues of potential impairment, like physicians with addiction, or other psychiatric illnesses or problems with aging. Back in the late 1970s, physician health programs started springing up around the country. Before that, medical boards looked at physicians with addiction issues as disciplinary problems. So only the most severe cases came before the board, and they were all disciplined. Treatment was really not an issue. They're just treated as bad doctors. Physician health programs started coming up around the country, and this confidential kind of way to approach physicians as a real person and a patient with a treatable condition started happening. And this stigma thing, I worked in treatment too, and a really key thing in helping a patient to break through denial, to gain understanding about the severity of their addiction. Like, I've had folks with 15 DUIs, or one patient had, 14 DUIs, and it's almost too much to believe. Got arrested for his 15th DUI in the parking lot of the courthouse. So, I mean, now we can't get away with that, but still, that insanity, if you polygraph that person, they could probably pass the polygraph and say it's not that big of a deal yet. You know, some of the denial is insane, and yet the person really believes it. And this is a finding we see in garden variety addiction. So if a person with addiction thinks, I'm just a bad person, the reason I do this is because I'm a dirty, low-down addict, then they don't really have to take responsibility for their behavior. Whereas if they look at it like, no, I'm a human being, and I have a fatal condition, if I don't take responsibility for it and do what I need to do, I'm not going to get better. See the difference there? So that's one thing we try to look at, like, you know, help a person to gain some responsibility, and by taking ownership of it and changing the way they look at it. So key principles: early detection, intervention. Our primary focus is on addictive illnesses. And then the real question is, can a physician or a nurse practitioner with an addiction problem, can they practice medicine safely? This is a legitimate question. Most of the public thinks absolutely no way, period. In fact, if we talk about a confidential track, the first question a lot of folks, lay people in the public, ask, well, who are the doctors on that list? Anyway, I know we're getting lunch. Usually I get a little bit of a laugh there. It's like Jeb Bush. Anyway, so our program was created by 2 psychiatrists in the Mississippi State Medical Association, and our monitoring is an intense process. For a physician to be involved with our program, it's an arduous process, but at the end of the day, if they're in our program and have our advocacy, that means we're letting the Board of Medical Licensure know this person is fit to practice medicine with reasonable skill and safety to the public. That is a huge statement. And to be able to say that, a lot of things have to take place. Like, for one thing, appropriate treatment. Dr. Mutziger was talking about treating safety-sensitive workers. This is a totally different animal than treating other folks in the general population, especially treating healthcare providers. Being able to break down the denial and cognitive distortion really takes a specialized staff, and it's much more effective in a cohort-specific, like with other healthcare providers, because when you violate the Hippocratic Oath, and these things are tough to deal with, so breaking through the shame and denial is necessary. So we only use providers who really have expertise treating that population. Once treatment is complete, folks sign a contract with us for 5 years, which involves random drug testing the whole time. Medication monitors. We do not allow a physician to practice, if they have a diagnosis of an addictive disorder, we don't allow them to practice medicine taking a controlled substance. All the evidence I've seen suggests that it's much harder for the brain to heal from an addiction problem if you're, activating that reward pathway with addictive drugs. So 2 really key principles that I hope you take out of this whole thing today is, one, when you're talking about treating addictive disorders in your patients, it's not a one-shot deal. It is a lifetime process. Just like you don't treat someone with type 2 diabetes with 1 shot of insulin or 1 week of hospitalization. It's a lifetime process that involves expenditure of energy into recovery-related activities, evaluating thought processes. And the other thing is this, if you're going to prescribe a controlled substance for a new person, if they've got a chronic condition that's not cancer-related, and everything that we're talking about is nothing to do with cancer-based, we're talking about treating chronic conditions that are not fatal. So if you're thinking about writing Xanax for your patient with anxiety, or treating somebody with a headache with an opiate, if you're talking about using it chronically, really think twice. And my hope is that you'll go through like 10 different things first, and in many cases that should be the last resort. We've got probably 2 million at least Americans today that are addicted to opiates, that are prescribed opiates, and we've got I don't know how many million Americans that are on benzodiazepines. We cannot just cut them all off, because that's going to create a public health crisis. So what do? Do you keep prescribing it? It's a real challenging thing. And further, there are some patients who are taking opiates chronically. They just need to be on them, period. So my real focus and all our focus is not creating new problems. That if we can stop that, because we're going to be saddled with this issue for probably the next 20 years. And when we look back on this 50 years from now, we're going to look at it the same way today we looked at those advertisements with doctors recommending that patients smoke cigarettes. It's going to be kind of in the same realm there. So the medical board, MACM, malpractice carriers, hospital credentialing committees, they want proof that a physician can practice safely. And I'm here to tell you that when a physician is in recovery from an addictive illness, most folks here, our lives all have been impacted by someone with addiction. And our lives have been impacted negatively by this. Most of us know a loved one who died because of addiction or was incarcerated. But also some of us know family members or loved ones who were able to get treatment and recover. And that is a beautiful sight. And I can tell you, when a physician's in our program and has our advocacy, what we see in 95% of the time is a turnaround. About 80% right off the bat will do a 180-degree turnaround. Malpractice rates are lower, risk of adverse events lower. These, physicians are really motivated, and a lot of times with addiction, they're practicing literally with a monkey on their back. And in most cases, really still practicing pretty good medicine. And when you take away addiction, you've got a really, really valuable asset. So, the physician health programs are based on contingency management. If they do what we need to do, they can practice medicine, and they do it safely, have a great life. If they don't do it, and we have to withdraw advocacy, then the medical board gets involved. We tell the medical board, look, unfortunately, we had to withdraw advocacy, and we are turning them over to you at this point. And if they suspend someone's license, what's that going to do to their livelihood? So that represents a huge stick. Practicing medicine and getting better is the carrot. And being able to do it with a confidential, non-disciplinary track is key. And this, there's some, I don't know if anyone saw the Clarion Ledger a couple weeks ago. The cover was the devil, a cartoon of a devil wearing a white lab coat. Did anyone see that? The title was "The Devil is in the Details." And it was about how the medical board in Mississippi is doing a terrible job. 15 years ago, they were ranked #1 in the nation in taking action against doctors with addiction. So they're ranked 50th by Consumer Report. So there's this idea that transparency and discipline equals patient safety. Now, the California Medical Board ranked #1. Their physician health program got shut down in 2008 because they ran it incompetently. But they should be monitoring 1% to 2% of the actively practicing doctors in the state. That's what most physician health programs do. That's what we do here in Mississippi, which means they should probably be monitoring 1,500 doctors. There's about 60 or 80,000 actively practicing doctors there. They don't have a physician health program. So for the medical board to get involved, they have to charge the physician. Their investigators have to get involved formulate an affidavit. They charge the physician, they have a hearing, then the physician's got their attorneys and the board's attorney prosecutes them and tries to prove to the medical board that they can't practice medicine with reasonable skill and safety. Then the medical board takes action against their license. That's what is necessary for a medical board to suspend someone's license. That can take 6 months to a year. Now today, I can get a call today about a physician and they can be in treatment tomorrow. And the medical board won't suspend their license as long as they do that. That process doesn't exist in California. So which state is safer as far as a patient being potentially harmed by an impaired physician? Mississippi or California? That's the rest of the story. On paper, it looks good. Oh yeah, they're tough on doctors. Well, at most, they're going to be able to take action against a couple hundred physicians in California. And so, anyway, anonymity is really important. Without a carrot, the process is meaningless. 15 years ago, our medical board prosecuted every physician in Mississippi that they knew about with an addiction. At that time, there was maybe 18 doctors who all had license suspensions, and so today we have about 115 physicians that are in our program monitored with our advocacy. That means they have jumped through a tremendous amount of hoops and have done a lot of things to be able to get advocacy. So are we safer today or back 15 years ago? Really, yeah. Without confidentiality, there's no incentive to get treatment. 15 years ago, someone with addiction, what are the chances that they would get treatment if they knew their license was going to be suspended? So this all kind of gets back to stigma and lack of education about addiction, even especially amongst us and the way that we're treating each other. So, okay, without confidentiality, results are not good. There are limits. If somebody relapses, they have a positive drug test, I have to notify the medical board within 24 hours. And they're pulled out of practice until they're proven safe. They may have to go back for a comprehensive evaluation. We talked about the California Physicians Health Program. If you look at nationally, one study of physician health programs over a 7.2-year period involves 16 states and 904 physicians. And what they found was at the end of 7.2 years, 78% of the physicians stayed sober without a single relapse. 7.2 years. And the testing we have now is really pretty good, and it's pretty easy to detect substance use. So that kind of success is phenomenal. If you look at folks who are returned to practice, they may have had one relapse or none, but they have advocacy, they're practicing safely. It's well above 90%. Can you imagine if we could apply some kind of a model like that to the general population? We could really get somewhere. But the key thing is lifetime involvement. For us, or long-term involvement. I've talked to folks all the time. Well, why do you require them to go to those meetings? They haven't had a drink in 2 years. But that lifetime involvement, longitudinal involvement is critical. Out of those 904 physicians, there was one case of documented patient harm, and that was from overprescribing. So this is the population that's safe. Dr. Craig is the medical director, or executive director of the medical board. He just retired a couple months ago. But he routinely said publicly he was not worried about people in the physician health program. He knew that they were safe. He's worried about the other 6,500 physicians. So to have our advocacy implies safety. It's a really good thing. And physician health programs throughout the country are similar. So management principles of addictive disorders. Longitudinal contingency management. Drug courts. Anyone here familiar with drug court? Several. So this is with nonviolent drug-related charges, DUI, possession of marijuana. Instead of incarcerating somebody, they can participate in drug courts. They may or may not get treatment, but their abstinence is documented with drug tests. And if they go to meetings, stay sober, the carrot is freedom. They don't go to jail. If they have a positive drug test, there are immediate consequences. They go to jail. So their success rate's in the 70% range at the end of 2 years. That's like, it's virtually the opposite in the general population. I think residential abstinence-based treatment is the best. 12-step participation, it is a wonderful thing. It's free, and it helps facilitate the process of return of normal executive function. It helps break through denial wonderfully, and it's free. It makes a person look at, what they're angry about, what they're resentful over, who they have harmed, and this is in detail. And amends have to be made for those harms for a person to stay sober. So a person accepts responsibility for their condition, and then they make it right. So very effective, and you can refer your patients to it. It works. Expect your patients to have denial and minimization about if they have an addiction problem. They're not going to tell you the truth. Their brain doesn't know the truth. I mean, really, truly. It's a hard thing to understand, but if you expect that, if you expect some denial or cognitive distortion, you'll be well ahead of the game. It doesn't excuse it, but so expect it, recommend treatment, and it really works. Last thing is maximize leverage. Use any leverage that you can. My success rate as an interventionist is like 99%. And because I go in there in 30 seconds, I say, look, do you want to practice medicine or not? And most of the time, some of them will say, well, some folks will fight and there'll be some denial and all that, but ultimately, most folks want to, protect their license. So in a lot of cases, there'll be a lot of resistance, and the person won't buy into it. But eventually, they go through the treatment process, they start to gain insight, then they realize, hey, this saved my life, much less being able to practice medicine. So the key thing is utilization of leverage. Like I say, look, if you do X, Y, Z, your life's going to get better. By the time I find out about a physician, usually its addiction is well advanced, because in general, we will do everything necessary to protect our medical license. By the time substance use becomes manifest in our practices, usually it's pretty advanced. So if you can use leverage, get family involvement, you'll have much more success. In prescribing acutely, use the minimum amount possible. The CDC guidelines recommend 3 to 7 days. The days of writing 30 Lortab, just take them as you need them. Most folks, they'll take 1 or 2 and they'll leave them in their cabinet, and then someone else will use them. So use minimum, and Dr. Mutzager talked about the risks of using them. If your patient has got an addictive disorder, if you're thinking about prescribing them a controlled substance, red flags should be going off big time. This is the highest of high-risk situations. Sometimes folks have to have surgery. They have to use substances. For a physician in our program, if they have to take a controlled substance, it's a really high-risk area, and we'll pull them out of practice first. I had one psychiatrist friend of mine, he used to give me a hard time about it, but initially we had some pretty serious arguments about, he wanted to put one of our physicians on Xanax because of tremendous fear of flying. Now, this person's an alcoholic in recovery. Why would that not be a good idea? So we're trying to alleviate the terror of flying, but what are the effects of benzodiazepines on executive function? Do they stimulate impulse control? No. They're associated with disinhibition. In some respects, you'd have the same effect if you said, well, just drink a shot of whiskey first. So anyway, you use a lot of caution if you're going to think about writing that for your patients. And that will be it. So we're done. Take an hour for lunch. Let's plan to start at 1:15, and we'll finish up early, okay? Thank you. Thanks.